Okay, so good afternoon, all of you out there. I can't see you, but I think you can see me. My name is Seema Azim. I'm consultant psychiatrist. Can you hear me all? Fine. Are there any problems? Just let us know. So I'm a old age psychiatrist working in Eastbourne in the community for assessment and treatment services based at St. Mary's House. So I was asked to talk on this topic, depression and anxiety disorder. It is quite a wide subject to, I think it would be difficult to cover it in 45 minutes or 1 hour. However, I think this is just the the baselines and highlights that I'm going to mention, but I thought perhaps I could add on to some case studies as well so that you can have some understanding of it. And I'm sure if you, whilst you are working in hospital settings, you are coming across um, all of the patients with much complexities because depression or anxiety disorder is not just straightforward as you would see in the books. Next slide, please. So, in terms of epidemiology of depression, there is a prevalence for about 4 to 7% of it, and the symptoms prevalence is 16 to 20%. There's a lifetime risk to have depression is 20%, and age of onset is between 20 to 50 years. It is more in females as compared to males, 2 is to 1, and excessive depression in women, it decreases with age, and it is more in men over 55. Next slide, please. It takes biggest toll, 10% of life years, the depression does, and which is twice than tuberculosis or roadside accidents. On average, 5 other individuals are severely affected by one person's serious depression. So, which is quite debilitating, not just for the person, but for the family or carers around them. And it is the fifth leading cause of disability after respiratory, perinatal, diarrhea control, HIV, or AIDS. I don't know about the latest statistics. One would want to know with the having pandemic for the last 2 years, but there you go. Next, please. So the etiology is quite widespread. It could be genetic, it could be biochemical because of the neurotransmitter abnormalities, neuroendocrine abnormalities, psychoimmunology. In the neuroimaging, there has been reduction seen. There's a reduction of caudate nucleosides in depression as well. Next slide, please. In terms of organic causes, there are a plethora of causes which can cause depression, or it can manifest as depression, like in hypothyroidism, like the symptoms of hypothyroidism sometimes may be uh, presented as depression. Hyperparathyroidism, Cushing syndrome, Addison's disease, infective causes, metabolic, neurological causes. I'm not just going to list all of them, but you can see that there are the organic causes which could lead to it. I will give you an example in a case study later on about the organic causes as we go along. Next slide, please. Then, how do we get, as a secondary care, how do we get a patient referred to us? As you know, it's all streamlined. From the primary care services, we do get the referrals to the secondary care services. If you're working in hospitals, patient can come directly to you via A&E, and then you see the patients, or the primary care services might refer the patients to CRHT. So in primary care, it is said that mostly 1 in 20 visits to doctors are due to depression. and more than 100 depressed patients per general population GP's list, but half of are recognized, and 20% develop chronic depression. And patient may not mention if they are having depression to the GP. There could be stigma around it. It could be that they are embarrassed. It could be somatization, and it could also be um, that they don't want to upset their doctor, and it might be that they avoid lack of sympathy. Um, Mainly, if mild to moderate depressions are treated by the primary care, the reason when they refer to our services is okay. So where were we? We were talking about the organic causes and how patients are referred to the GPs first, and then it comes to the reasons. The next slide is about the reason to referral to psychiatric services or specialist services. When GPs have concerns about the patient, if it has become untreatable, for example, if there is a high risk of suicide, most important concern, when there is a failure to respond to the usual treatment, when they are having difficulties in diagnosing, if there are any comorbid conditions which are contributing to or making treatment for depression worse, or if it has worsened to the extent that they are presenting with psychotic depression, which may require combination of treatment with either antidepressants, antipsychotics, or ECT in that sense. And also, they are referred when patients with bipolar disorder who may present with a higher suicide risk during depressed phases, and they may need or they may need careful monitoring of mood stabilizer, for example, lithium. It is a standard agreement between the primary and secondary care services that whoever is on lithium, even if they are stabilized on lithium, the monitoring is done by community services, secondary care services, for which serum lithium tests are done after every 3 months, and thyroid function test, kidney function test, and calcium levels, they are also checked after every 6 months, and weight is checked annually. So therefore, the GP would present to us. Can you all hear me?
Yes, I can hear you.
I can,
Okay, all
yes.
right, okay. So now the next slide is about the diagnostic features of depression. The core features of depression are that it has to be a pervasive low mood, at least for 2 weeks, loss of interest and enjoyment, reduced energy. They are not interested in the activities they may have enjoyed before. And other features would include their loss of concentration or poor concentration and attention. They would have poor self esteem, ideas of guilt, not feeling worthy of themselves, have very pessimistic views about the future. Some patient would say, I'm in a black hole. They would have ideas or acts of self harm or suicidal ideas, disturbed sleep, and diminished appetite, or and with the weight loss. So
Hi,
the
sorry to interrupt. I'm sorry, the computer decided to turn itself off and do updates in the middle of your presentation.
don't worry. What I have done is that I don't know whether it could be fixed or not, but I have gone on to my own presentation on the computer, and if it cannot be fixed, then the slides will be sent to the all of the doctors.
Yeah, I
Uh,
should be able to bring it back up. Just want to
oh,
apologise
good,
for
good,
that.
good. So, do you want me to halt here and wait for you to put it back up?
You see that now?
Okay, let's do that then.
Can you see it?
Yes,
I
I
can see
can.
it, yeah.
Yes, yeah,
The right
yeah.
slide.
Okay, yeah, we are back to normal. So if you keep going down, we have gone to the classification of we've done organic causes. We've done depression in primary care, secondary care, um, referral to psychiatric services. That's done. Um, that's been done. The next slide, please. Yeah. So classification of depression. Normally, we get the guidelines from. Thank you, Anita. We get the guidelines from ICD-10. I know that there's ICD-10, ICD-11 there as well, but we're still following that. So they are the primary in the primary classification, you will see unipolar, which is mixed anxiety and depressive disorder, and with prominent anxiety, depressive episodes, recurrent depressive disorder, dysthymia, which might be persistent or mild, then bipolar affective disorder, and then cyclothymia, and other primary in the classification is seasonal affective disorders or brief reactive depression. Next slide, please. Recurrent depression. So, according to the NICE guidelines for the treatment, this is just a summary that I have put in the NICE guidelines. The antidepressants are not recommended as a first line of treatment if somebody is presenting with mild depression. Normally, patients don't come to us with mild depression; they will be treated by the GPs. And the guidelines say that, do just the active monitoring, some self-help guidelines, or if it's needed, CBT. Um, Antidepressants, they are used for moderate to severe depression, and we start with SSRIs, which are recommended. Um, patient, it's always discussed with the patient, so they are given a choice about, what treatments are available, and explain to them about the side effects. In the community, we give them the deep leaflet about the all of the side effects, about the information about the side effects of the medication as well. All of the withdrawal effects are explained to them, and it is also advised to them not to stop the medication because of the discontinuation effects. Um, so if a patient presents with treatment resistant depression, then of course it changes to, then you may have to do augmentation with lithium antipsychotics, or adding a second antidepressant. And this is not always in the same way of, first using the lithium antipsychotic. It would depend on their symptoms. And patients with the NICE guidelines says that patients with 2 prior episodes of depression, and if they have got functional impairment as well, please read impairment, not treatment. This is a typo. They should be treated for at least 2 years. The patient will come to you and say, doctor, how long should I carry on? So this is the suggestion. And ECT is used in severe and treatment resistant depression. And severe, I mean when there is um, depression with psychosis. Next slide, please. So the pharmacological treatment, again, I mean, there's a plethora of treatments available from medicine's point of view, for the treatment of depression. In old days, tricyclic antidepressants were used, MOIs were used, but mainly, I mean, we try these days, it's the cleaner drugs which are used with less side effects. Serotonin, I mean, the SSRIs, they are the main line of treatment. Um, Previously, it was fluoxetine, paroxetine, sertraline, citalopram, then escitalopram was added. Fluvoxamine was already there, and now you would see that there is new medication called vortioxetine, which is also being used. Um, then, I mean, there's a whole list of it: uh, trazodone, venlafaxine, mirtazapine, duloxetine. And then there's an augmentation with the mood stabilizers as well, and antipsychotics, and ECT. And as I've said, it cannot be, it's not, there's no strict rules that it has to be in that order. It will depend on the symptoms of the patients, what and when to use. Next slide, please. I mean, theoretically, some other drugs are also available to be used. We are allowed to use them, which are listed here. Personally, I don't think I have ever used them in my practice, but there they are. So, next slide, please. So, for the treatment of depression, we mainly use the biopsychosocial model. So, we have got medicines available. Then there's psychosocial interventions, which are also pertinent to be used um, and taken into consideration. You may have seen that if you do the clocking in hospitals about the 5 Ps: precipitating factors, perpetuating factors, um, predisposing factors, protective factors, and they will give you a huge number of information about how this has happened, why this patient is presenting with depression now. So psychological interventions is to minimize the adverse life events. For example, if there is any financial difficulties that they are coming across or that has led to episode of depression, and promoting secure confiding relationship if there is a relationship breakdown. And then psychotherapy is also available, like CBT and interpersonal therapy. As you can understand, or I'm sure you do see that in your daily practice, that in psychiatry, there is a whole multidisciplinary team. So the uh, us working as clinicians, as doctors, we are also working with psychologists, with occupational therapists, with, of course, with the nurses. So the psychologist would also provide treatment for all these purposes, um, along with the medication, or sometimes medication is not used, and that may be the mainstay of the treatment. It would be depending on the case. Next slide, please. And before we go into the case study, I mean, there's now something called social prescribing is also in vogue, which is, people, for those who are in isolation, who would uh, who would need some help with how to manage with the loneliness, which we normally come across, because I'm an old age psychiatrist, so we do come across these situations. This is a case study I wanted to discuss with you, just to get an idea. I mean, as I've said, depression can be presented with in many shapes and forms. I have yet to see a clear-cut, classic book picture of depression in my career. You don't see that very often. It you we all always come across the more complex cases, so to speak. So this was an 80 years old lady. Um, he has had a bereavement. Her husband died of roadside accident, so it was sudden about 2 years ago. Um, and um, and family had noticed that she was becoming withdrawn. She was becoming isolative. She had loss of appetite. She had weight loss. She was not looking after herself, and this was uncharacteristic of her, that she would not take care of her personal um, hygiene. She was confused, not having any conversation, and her speech would be like monosyllabic, yes and no kind of answers. And she was not interested in seeing her family or friends, and nor neither her grandchildren, which was quite a big setback for the family. They were concerned. So um, so she was seen by the GP. GP had started on the antidepressant, which was not much effective. And I think I've also forgot to mention about the disturbed sleep. So I had seen her. Um, when history taking in psychiatry is very, very, very important. I can't overemphasize it. When I was asking about the pre-morbid personality, they said, just before her husband died, she was the most extrovert lady, very engaging in her social life with the family. She would be life and soul of the family gatherings, and uh, and then she stops facing everyone. And the main positive factor was that she wanted to get better because she said, "This is not me," but she did not know what was going on. So this was a case of severe depression. However, she did not have any psychosis. So I did change her medication, antidepressants. Um, Mirtazapine helps with if people come with insomnia or disturbed sleep and depression, it does help. So if you wanted to start someone on an antidepressant with disturbed sleep, you start giving them, like, start with 15 milligrams and build up the dose to 45, which is the maximum dose. And we have got something called intensive support team, which is a group of nurses, part of the elderly um, mental health services. And I did the referral to them, so they were monitoring her more because of the medication, and then also helping her to build up her confidence, um, and gradually getting her becoming more confident in going out, because she was becoming very isolative. So it took about 6 months' time, but it was a good success story that she recovered really well. And we started seeing noticing the difference in her as well. Um, so psychological support was not provided by the psychologist as such, but our team of nurses, which I've mentioned about the intensive support team, they did work with her, and it really worked wonders. So, next slide, please. The next case study I wanted to mention is pretty complicated. I mean, she's just recently discharged from hospital, a 70 years old lady, married. She was completely functional, fully functional, in fact, and she was the main person in the house who was running all of the business in the house, all financial affairs. She was also like manager of a bowling club as well. Um, at Before the lockdown, she had had some altercation with some of the members of the bowling club. That was the only factor that we had come across. But during the lockdown, with the isolation, she was becoming more and more withdrawn, becoming depressed, and there was no history of depression in the past. She had a lack of sleep, she was neglecting herself, she was becoming more and more confused, and she was also becoming um, uh, she had massive psychomotor retardation, almost catatonic in presentation. And she was becoming psychotic as well. And so the husband felt that she was hallucinating as well. So, and this lady with the background of suicide in the family, sister had committed suicide about in her sister in her 40s, and they were like 1 year apart. And the niece had also committed suicide on the death anniversary, first death anniversary of the mother. So that was the history. But this lady had been like a manager in a hospital somewhere in Cambridge, and the daughter was working as a director in Addenbrooke's hospital. Um, so because of this confusion, she was admitted to hospital in DGH, and she had neurological consultations and investigations, and it was inconclusive. Um, CRH liaison team was involved. She was started on antidepressants and antipsychotics, and she was discharged home. Um, Then the daughter took her to Cambridge and had another investigations and consultations done by the neurologist in Edinburgh, and it was still inconclusive. So she came back to Eastbourne. GP did the urgent referral that husband can't manage, and you see her again. So when we saw her, since she was on antipsychotics, she was presenting with severe extrapyramidal side effects. And she was almost, the body posture was rigid. She was had cogwheel rigidity as well, tremors, salivation. And she was on risperidone at the time, along with mirtazapine as well. So we did manage to take her off antipsychotics slowly and gradually, and I thought it was just extrapyramidal side effects. But when I was seeing her again, intensive support team were involved. It noticed that psychomotor retardation had actually not improved. Um, some improvement with her hygiene, that's all. Um, it, there was as you know, initially in the initial slides, I had mentioned that it affects about in one in about five people around that person. They are also affected with this disability, and you could see the impact on the husband. He could not cope. He himself was becoming depressed and almost suicidal. We had to get her admitted in hospital, and she ultimately received treatment with ECT, and with good effect. But it took quite a long period for her to be discharged home, and she just was gone home with pretty stable mental condition. Um, we had to deal with the husband now. He was becoming more and more depressed. He's still under treatment, but she's doing very, very, very well. So ECT did do well for her. Next slide, please. I would say that please feel free to ask any questions in between. You can interrupt anytime if you want. So, in summary, depression, I mean, there are several forms of depressive disorder, but clear criteria exist for diagnosis, which is presence of specific features for at least 2 weeks. So, the moderate depression is sufficient to prevent normal functioning. I mean, you can hear people loosely saying, "Oh, I'm depressed." I mean, clinical depression is different from, when people say they are depressed. I mean, they have to be clinically depressed, like, all of the features that I have mentioned about biopsychosocial features. And it also prevents them from normal functioning, as I mentioned in case two, that she was totally different to what she was like before the episode. So it causes functional impairment, and they respond to both antidepressants, CBT. Severe depression may require additional antipsychotic medication or ECT, as mentioned. And depressive episodes, they are often either they are undertreated, they might have too low dose of antidepressant or for too short time, or changing drugs too frequently, or it could be the non-compliance on the part of the patient. They would not take the medication, sometimes without your knowledge, and it will be untreated. I have, next slide, please. With this depression, I wanted to have some separate slides for suicide, because you will see when you work on the wards, mainly general adult, or CRHD, that m- I think majority of our work is revolves around suicide or deliberate self-harm. And if somebody presents with them, with these thoughts or episodes, the question need to be asked it when you do the risk assessment, that what was the motive behind it? Why now? What has happened now? Person might say that, I've been depressed for many years, but why is this patient presenting with thoughts of suicide or deliberate self-harm now? What were the circumstances of attempt? whether this person has any psychiatric disorder or not. Because in A&E, sometimes you might see somebody coming with deliberate self-harm after having a fallout with their partner. So, what were the precipitating and maintaining problems? What kind of coping skills they have got? Have they got any support? And what were the risks, as we have discussed initially in the etiology and the epidemiology? Next slide, please. So, what are the high risk indicators of suicide? It's according to the evidence, male, more than 40 years of age, family history of suicide, unemployment, if they're socially isolated, and always ask, make sure that whenever whoever presents with deliberate self-harm or attempt at suicide, whether they had left any suicidal note, um, continued desire to die, feeling of hopelessness, pessimistic about the future. There might be misuse of drugs or alcohol, and could be psychiatric illness, or depression, or schizophrenia, or personality disorder. Next slide, please. So before we go on to anxiety disorders, did anyone have any questions about depression? Or did they want to share anything of their experiences so far? Okay. So anxiety disorders. If you go on to the ICD-10, you will come across all of the anxiety disorders. There's a list of it, of course. The panic disorders, they are 1 to 2% more in women, according to the epidemiology. Generalized anxiety disorders are 4 to 6% more in men. Obsessive compulsive disorders are 1 to 3%. I mean, in anxiety disorders, they're 1 to 3% is OCD. Then there's acute stress reaction. There are phobic disorders, and there are post-traumatic stress disorders. I am I was not able to cover everything, but I thought I could um, discuss the symptoms of anxiety disorders and the how the diagnosis of generalized anxiety disorder is done, and how acute stress reaction is presented. Perhaps for next time I can elaborate on the rest of them as well. Is that okay? So next slide, please. So the symptoms of anxiety, they could be psychological, they could be cardiovascular, respiratory, neurological, general. Patient might present with very restless, irritable, poor concentration. There might be fear of death and heart attack, um, chest pains, palpitations, shortness of breath, feeling dizzy, having headache, vertigo. And in general, there might be tiredness, insomnia, sweating, libido, loss of libido, frequency of urine, muscle aches. Next slide, please. So, for the diagnosis of generalized anxiety disorder, it has to be persistent more than 6 months, free floating anxiety, with disturbed sleep, restlessness, tremors, tension, overactivity, maybe secondary to other psychiatric disorders. Make sure that you exclude any physical disorders. Next slide, please. So, what is acute stress reaction? It occurs within minutes to hours in a dazed or disorientated state with very prominent anxiety features. There might be numbness, detachment, derealization, depersonalization, or dissociative amnesia. If anything, in my experience, I have normally seen these in whenever I would be on call in A&E, these acute stress reactions. They may be agitated, stuporose. Um, Usually, they don't have any pre-morbid psychiatric diagnosis, and there is a complete resolution as well within a short period. According to ICD-10, they say the resolution is within 2 to 3 days, but DSM-4 says resolution may persist for 2 4 weeks. Next slide, please. So this case study is about not about the acute stress reaction. This case is about a patient who presented with generalized anxiety disorder. 69 years old married lady. She lived most of her life in France, and what had happened? There was an incident in France. She was in a like a market fair, and she accidentally locked in a those big freezers. She got accidentally locked in there for I think for half an hour or so, and following that she had episodes of severe anxiety and was restless, breathlessness, was seeking constant reassurance from her husband. He could not cope. So they decided move back to UK for more family support. She's got a caring son and daughter. When we started seeing her, GP did the referral to us, and we started seeing her. She could hardly make any construct any sentence. She was very, very breathless and hyperventilating, was not able to go out. She was housebound. She was having relationship problems as well. She's felt that her husband could not understand her level of illness that she is presenting with. So, and she had severe functional impairment. She was not able to do even perform any simple tasks at home, and would seek a reassurance from her husband all the time. Um, so, functional impairment in her case, extreme restlessness, hyperventilation, and having relationship issues. She was treated with antidepressant, but we did have psychologist involved in her care. She's still under treatment, but she's better than before, I would say. Next slide, please. So this is a very interesting case. She's a widow who lived on her own with a dog af- after her husband died. She had an acute onset of severe anxiety, and on top of that, she was having auditory hallucinations to the extent that she was frequently calling police for someone knocking on the door in the middle of the night, and they would come, would not find any evidence. She was also constantly phoning family for the support. So the precipitating factors in her case was that sadly, her son-in-law was diagnosed with cancer, and she was concerned about the daughter because the son-in-law was diagnosed about the same age when her own husband was diagnosed with cancer, and she was worried about the daughter and what would happen to the son-in-law. And at the time, she also all had her own health issues, like she had some uh, dental treatment that needed to be done, which was quite nerve-wracking for her. It took a long time for us to manage her. We treated her to start with antidepressant that did not work. Of course, anxiolytics were added, and then she was also treated with antipsychotic. We had involvement of an intensive support team and psychological input for her, and she thankfully is doing very well at the moment. But she's still under our care. I mean, she's not been discharged. Next slide, please. So, anxiety disorders, in summary, it's a common but very unpleasant experience that might be a normal reaction to circumstances, but it can also become very chronic and debilitating for the person and people around them. And it should also always be differentiated from each other, the other type that I've mentioned, and from other reactions to stress, as their optimal treatment would differ. There are self help manuals available, or patient support groups assist many patients in overcoming their anxiety without recourse to specialist treatment. Psychological interventions is indicated in most moderately severe anxiety disorders alone or in combination with medication. Any questions? I'm going to stop here. Feel free to ask any questions, please. As I've said, this is just a highlight because it's a very vast subject, but just give you an understanding of how it presents. What you could realize that it does not come as a clear cut as it would be in in the books. You might come across depression in bipolar affective disorder as well. It could be somebody suffering from schizophrenia and they suffer from depression, or people presenting with mixed anxiety and depressive disorder. So this was just a highlights of anxiety and depression. I would welcome any questions if you have any, or if you wanted to know more about it.
One seems quite quiet.
They are.
Nothing on the chat, I don't think either.
No, nothing in the chat. So does that mean we can stop here then?
Yes.
Okay, all right.
Thank you very much for teaching.
And thank you very much for everyone for their attention. And thank you, Anita, for organizing all that.